So what I want to talk about today, and I think from listening to a lot of the talks this morning, is perhaps a different type of the practice of design in healthcare. And so my hope is that it's really relevant to the designers that are here to think about how it might affect or change the way that they actually practice design. And also for the other people that are here, whether they're more CEOs or developers or in different ways involved in kind of startups around healthcare applications, to think about how are you using design and the design people that you have around you, and maybe are there different ways to think about using them in the process. So that's really kind of my goal here. I wanted to start just by kind of telling you a little bit who I am and why you should listen to me. Now, and you may decide that you don't need to listen to me, which is totally fine. But I think it helps to kind of set the stage a little bit. My title is a designer researcher. I spent the last almost 7 years working in the Center for Innovation at Mayo Clinic. For those of you who might not know, Mayo Clinic is a healthcare institution. It's over 100 years old. It employs around 55,000 people. It has 3 primary locations for its sort of specialty hospital and outpatient practices in Rochester, Minnesota, Jacksonville, Florida, Scottsdale, Arizona. It also has a full suite of a healthcare system that spans, I think, around 13 sites in Wisconsin, Minnesota, and Iowa, often very rural settings. It has kind of everything under one roof. So it's specialty practice and primary care. It has imaging. It has pathology. It has hospitals. It has outpatient practices. It is self-insured. So for all those people and their 55,000 people and their dependents, Mayo sort of pays its own insurance. And so the result of all of that is that it's really a microcosm of the complexity of healthcare delivery. It is a place where we actually have all of those pieces under one roof. And so for the last 7 years or so, I have spent a lot of time with all of the people that make up that system. So it's both physicians and nurses and patients and their families, and so all the different people, which also includes, things that we don't always think about, like the facilities group and the IT group and the kind of ecosystems within the cities and the towns that kind of make up the support network for a place like Mayo Clinic. And I think all of that experience has given me a little bit different idea of what it means to design within healthcare. The work that I have done is not so much focused on consumer-facing products, but much more about how do you affect the complex systems that are how we actually deliver healthcare. And what I've kind of learned from that is that the type of design I practice is really different. And I think it's a type of design that is much less focused on what I make and much more focused on how I make it. And I say I, and really it's much more of a collaborative effort. The Center for Innovation is a multidisciplinary team of people that come together to do this type of work. But what's interesting is if I were to tell you, so often people are like, okay, you're a designer at Mayo Clinic, so what do you make? What is your like end product? And I could tell you a lot of those, and they would seem so mundane as to be almost boring to you. We do space, so we do sometimes space redesigns. If I'm truly being honest, sometimes I would take you down to a care team that sits in a certain area and say, now this care team actually gets along and talks to each other. 6 months ago, they didn't. And so that's the kind of reality of what it actually means to sort of do a lot of this type of work. And I think that while there's enormous value in a lot of the consumer-facing stuff, and I'm in no way opposed to that, I think that the opportunity to affect really big change in the healthcare system is much more by directing kind of inwards. And what I'm hoping to do today is kind of bring forward or sort of show some paths for how you might be able to begin to build those relationships and begin to do that type of work. So I was going to start off a little bit. These are kind of axioms that are principles that I kind of use and live by, and I think they're helpful to kind of understand as we go forward what's maybe kind of unique about the point of view that I'm bringing here. And the first one is kind of what I think of the definition of design. This is the definition of design that I kind of use and live by. That design is creation according to a plan. And what's really interesting about this definition to me is that you probably all very easily see yourselves in this definition. Design is certainly not an activity that's only done by designers. And I think that a lot of times, one of the challenges that I've seen when we try and do the type of collaborative and multidisciplinary work that is critical to confronting issues and problems like healthcare, we bring a lot of people together and they don't know how to talk to each other. And there ends up being a lot of infighting over kind of who owns what part and who's responsible for what part. And that happens a lot with design, I think, because there's kind of big D design and little d design. And I think that design is really this creation according to a plan. So all of us are designing. Anyone who sets out to create a startup or another type of tool is doing an active design. I think one thing that designers can bring to the table is that they're experts in two parts of this. Their training is in two parts of this. One is in the act of creation, of actually making things that come into the world. And I think that this is critically important in healthcare in particular. I'm often fond of saying that if somebody puts a moratorium on healthcare ideas, healthcare delivery ideas tomorrow, we would all be fine for decades. Every idea to improve healthcare has been thought of in some form or another. Our problem is that we can't figure out how to actually make them real in the world. And so that's where I think there's a huge opportunity for design to really begin to kind of pick up where we have the ideas and figure out how to make them real. And increasingly, design and designers come with a background of research. And that's really all about according to a plan. So this is what I think makes this sort of definition of design so interesting, is it's not just about the act of making something, but it's actually about the act of creating the plan. And one thing I definitely applaud Mayo Clinic and the Center for Innovation for doing, and that I think was really critical to our process, is that they invited designers to sit at the table at the creation of the plan. And not everyone always does that. And I think what I hope to sort of show you through the rest of the talk is what the value of that activity may be, about bringing designers to the table at the very beginning and allowing them to have some sort of an input. The second sort of axiom, which has been stated many times yesterday and I think in probably every presentation today, is that this one, changing healthcare means changing behavior. That's kind of what it all boils down to. I think it's really important here, though, not to just think about patients. It's not just about changing patients' behavior. It's actually also about changing physicians' behavior, researchers' behavior, nurses' behavior, administrators' behavior, hospitals' behavior, and you get bigger and bigger payers' behavior. All of those things are ultimately going to have to change, and oftentimes they have to all change at the same time in order for you to test a really big idea. And so this idea about how do you begin to, this sort of goal about how do you get towards changing behavior, I think is a really interesting one for us to think creatively about how do we engage in the relationships that are actually going to allow us to experiment and test in those types of ways. Because I'm not sure that the systems that we have set up, especially for doing a lot of the work right now, everybody being very siloed, are actually best set up for the types of relationships that really get to sort of the changes in behavior. And I don't have the third one in here, but it actually occurred to me as I was listening to some of the talks this morning, and it is a really big belief of mine, and so I'm just going to throw it in even without a slide, which is it's also really important to remember that there are no bad people in the healthcare system. Nobody is trying to do anything maliciously. Patients aren't trying to disappoint people. Doctors are not trying to do, bad things or to hurt people. It is a place where we have really good people who are caught in a really bad system. And our job as innovators and as designers is really to think about how do we change that system. And I think it's incredibly important as you go through and do the work to remember that the focus, the thing that's failing is the system, not the people. Because it's very easy for blame towards the people to kind of creep in. So I had this idea. I was trying to think, if I wanted to share information with you, how would I begin to do that? And I started with, I could share some of the projects that we've worked on, but that seemed to kind of just defeat the whole thing that I just said at the beginning, which is the type of design that we practice really isn't about what we make in the end. It's much more about what's the process for bringing people together, and what are the types of questions that we ask as we build out that plan in order to kind of get to the creation phase. So I thought I would experiment and try a slightly different approach, which is, I've got 6 questions here, which I think are somewhat representative of the types of questions that I would push and probe and ask to do research on. If you were starting up a company and you decided to have a designer on board and you said I could come and sit at the table, this is the type of stuff that I would ask, or that I would kind of push. And I can share a little bit about what these questions have revealed in some of the work that we've done at Mayo Clinic. So the first one is whose behavior has to change? I think this is an incredibly interesting question because we don't always really, we sort of assume that many people's behavior is unchangeable in the system, and that's where I see a lot of the focus ends up being on the patient. Well, we have to get the patient to be different. Well, there's lots of people in a broken system, and all of them need to behave differently, and we have to think about how we motivate all of those people. So for instance, we have a project that just recently, that kind of just recently got greenlit at Mayo, which is the first new exam room design at Mayo Clinic in 50 years. Really 100 years. 50 years ago, they moved the couch from one side of the room to the other, and then it stayed the same for about 50 years. And we just finally got a new room design, which we call Jack and Jill rooms, approved and built into one of the new facilities, one of the new practices as they're moving into a new floor. The first inklings of this project actually started 5 years ago. And the process of doing it, the hardest people to sort of convince, the biggest part of that was not the doctors, it wasn't the patients. Many of those things, their kind of enthusiasm and interest in the idea came very quickly. The biggest group that it took that long to kind of convince was our facilities group. And for them to really, a very conservative, very risk-averse group within the organization, it was a lot of slow prodding and pushing and encouraging and being supportive, and then sometimes backing off and then bringing the idea forward again when other people started to talk about it. It was really, that was kind of the role of the Center for Innovation. It wasn't to come up with the most amazing exam room that anybody had ever seen. If I showed it to you, you would be surprised. Again, you'd say, really, that took that long. But I think that that's the reality of the complex systems that we work in, that a lot of the work of design or of doing innovation is about being a partner and being willing to kind of be there over time and recognize that in order for us to actually really do something new, we have to get all these different people on board. So for instance, and so that's an example of a different group whose behavior had to change. So the other question that that I think is really important is to understand, why do they currently act that way? So nobody who's acting in the healthcare system is acting that way completely irrationally. It's come from a particular reason or place. So this is one of the kind of ideas that I give to people, is if you really want to work in healthcare innovation, you really have to become a student of history. You have to really understand how we got the systems that we have today. So for instance, I know there was a lot of talk yesterday about the fee-for-service system. So one of the things I find so interesting is everybody kind of talks about how it's so crazy that if you're a person who has diabetes and you just want, you go to the doctor more often, nobody's willing, physician doesn't get reimbursed for that very much, and payers don't necessarily want to pay for that, but then when the time comes that you have to have your foot amputated, that's something that everybody makes a whole lot of money on. So where's all the incentive, how our incentives get all out of whack. So interestingly, in the 1970s, when the first they brought together a whole lot of physicians who essentially sat around a big table in Washington, D.C., and people decided, okay, what's going to be the cost for every service that we have in healthcare? That table was filled with a lot more surgeons than anybody else. So the repercussions of that are that, what do we pay the most for? We pay the most for procedures and surgeries. And I think it's really important for us to kind of understand how those things came to be, because it becomes a critical part of thinking about how do you how do you begin to change that? How do you begin to build an argument that suggests there's a different way of doing something? And I think that sort of hits, if there's anything that I design regularly, it's arguments. That's essentially what a plan is. It's a plan for how you should be doing something differently. The third question that we ask a lot is there a desire to act differently? A lot of people have talked today about, sort of a compliance. I think compliance is a really interesting space. So again, sort of going back to the idea of diabetes. So one of my colleagues that I work with a lot did a research study and found that if people with diabetes in general, if they do everything that their physicians ask them to do, it would be an extra 140 minutes a day, which is essentially a part-time job, which then says it's pretty rational reasons why people choose not to take their medications. There are I've seen lots of patients who have many very good, valid reasons for not wanting to take their medications. So a lot of the work that we've done around a lot of the decision aid work that I've done has been less about the goal of compliance, potentially, although sometimes that's one thing that's measured in the final research study, but much more about how do you create an open dialogue so that patients can feel comfortable saying to the physician, I understand my risk, I'm not willing to accept this trade-off. I would prefer not to take the medication and accept the risk than take the medication. That's a perfectly reasonable decision for people to make, but it's not something that's actually presented to them or shared with them. The information about the risk isn't shared with them, and then they don't get an opportunity to say, here's what I choose. I choose to put my energy and focus over here, and that to be heard by the healthcare system and kind of responded to. So again, there's a lot of, each time that you're kind of looking at an issue or attacking a problem, there can be a whole lot of value in picking it apart and really understanding where is it reasonable for people to choose not to act. So the fourth then is what might help or encourage people to act differently. And a lot of the work I see, this is the place, and then kind of the next one, to the place where people begin to, where they begin the process. And I think that's part of the challenge, is that you don't want to just immediately leap to assuming that you understand exactly what's going on in the situation and then thinking about the concept or what might be able to happen there. This is, we think a lot about this if you start to think about care teams, for instance. So we've done a lot of work around care teams. So what might help or encourage people to act differently? One of the big ideas that we've sort of worked with and shared there, and again, sometimes these ideas are so mundane that they kind of shock you, is right now everybody is kind of very separated. They're very split apart. And nobody sees each other. So, one long-term experiment we did and what we've kind of pushed to is actually having big team rooms. So just a space where everybody actually works in the same space, and suddenly now there's an opportunity for them to share information when they're just kind of dropping in. And this is inevitably, we did an experiment where we had 4 physicians share a kind of shared workspace along with clinical assistants and nurses for a month. And we kind of asked them about what they thought would happen before they got there, and they told us, we won't have any time to talk to each other. And we said, okay, well, we appreciate you're still doing it for us and still, doing the experiment. And then it was mere days before they were sharing information, asking, how do I get a patient into neurology? Have you ever seen this type of thing before? And so I think that it's very often when you get to the sort of thinking about what might help or encourage people to act differently, it's oftentimes, as much as I love technology, it's oftentimes not a big technology solution. Oftentimes the solutions can be really small, and then thinking about how you grow them or expand them can be supported with technology. Another is, how could a concept begin to support these new behaviors? So if these are the types of things that you want people to be able to do, then how do you begin to build something that might help them do that? And this is the area that I think a lot of the conversations already today have kind of spoken to, and I think particular relevance around doing a lot of experimentation and thinking about what's really the opportunity that we have here, and being able to identify what's actually indications of the behavior that you want. So for instance, a lot of the decision aid work that we did we realized that what we were looking for was the ability for people to have a conversation with each other. And that was indicated by, we decided that kind of our metric that we would look for was how do patients actually ask questions? Can they ask questions in a situation where oftentimes they weren't? One of the things that we noticed was patients who, when a patient asks a question, that's a way of them expressing their values and preferences to a physician. And then by and large, the physician is prepared then, now knowing that information, to customize a response or to say, oh, if this is what's really important to you, then here's what I can tell you about the wealth of knowledge that I have, either from medical knowledge or from his own personal experience or her own personal experience in an area. And then the sixth one is, what do you wish you had more confidence about? And this is really, all the questions that you kind of ask up until a certain point are inevitably going to be a series of your own assumptions about what you think is going to work. And to be able to make those explicit, I think, is really important. And there comes a time when you then say, well, I think that this is true, but I don't know that this is true. And what could you do? What could you try out in order to see if you can gain more confidence about that particular idea? And I think that this really speaks to kind of the prototyping idea that was mentioned before, although in the center we've taken a real approach of kind of expanding the idea of prototypes and thinking more about experiments. So an experiment can be a prototype, but not all prototypes are experiments. And so sometimes you're just asking a general question. You're not necessarily seeing if this particular solution works. And there's huge value in partnerships and relationships with people who will allow you to ask these questions in live clinical settings and really be able to see what sort of effect they actually have. We've been working on a decision aid that is for, it's the hardest one I've ever worked on, that's for people in the preoperative area who are smokers, to give them the option of deciding whether or not they want to stop smoking, or what we call quit for a bit, which is quit around the time of their surgery, or continue smoking. And it's been a really fascinating experiment because, and we've gone around and around and trying to get a conversation going, because there ends up being so many interesting things at play here. First of all, nobody gets to that level without having heard that they should stop. No patient gets there without having heard they should stop smoking before. So they're already kind of immune to this conversation, and they don't really want to have it at all. Physicians are kind of scarred from bringing up the conversation with patients and being yelled at, so they immediately retreat. It's not a conversation that they're interested in having either. And yet there's this huge opportunity that we feel is really important to create a space where at least we can bring forward information that they may not know, which is that there's huge value even in just stopping smoking right around the time of your surgery. There's huge value in terms of your healing and wound healing and increasing blood that's pumping through your body and those types of things. And so this has been an enormous kind of challenge for us, and as we've built experiment after experiment to try and make it happen, it's really teased out what are some of the issues on the physician side and what are some of the issues on the patient side. And I think what's really valuable about it is it showed us that if had we gone with our first idea, it wouldn't necessarily have gotten us where we needed to go. And that each one was really an experiment for us to learn a little bit more about what people resonated with and what people didn't. So those are kind of 6 sort of example questions that we kind of ask and we sort of push in all of our work. And I think that they reflect potentially a different type of design than you might normally find in the healthcare practice. And I think one that has enormous opportunity. I know I'm almost out of time, so the one thing that I would leave you with is I think that in the work of healthcare innovation and healthcare delivery design, I think that you need at least as much, if not more, creativity applied to the process of how you do it than you do to the concept or the idea itself. So, thank you.